Thank you very much. I apologize. This meeting is you're running left and right. You barely know where you're going. But I think when they asked me, would you look at the data and tell us if you think this is a good biomarker? That's how our relationship started. The company asked me to look at the data as sort of an external person that was not involved in the trial, that had nothing to do with the design of the study, and would have a critical mind, try to see, is this biomarker, could this biomarker potentially have a clinical utility, not only in an abstract way, and I hope in the next few minutes I can convince you that that is the case for this biomarker. These are my disclosures, as you can see, quite promiscuous and working a lot on biomarkers. So to set up the stage, and I'm sure Fred already talked about this, the main issue in bladder cancer, I mean there are many issues, is that not only it's a disease that is quite demanding on the patient and his family and their surrounding, but also as a public health and socioeconomic issue, and that is where specifically non-muscle invasive, it's driving the cost of care dramatically. This is due to the frequent cystoscopies, high rate of recurrence, and a chronic disease. We are unfortunately failing in delivering what we promise our patients, that is a better care, a better survival, a better future. Survival has kept the same. The number of interventions we're doing is quite too many and are not serving our patients well. So I think we are failing to a certain degree because we have limited awareness of bladder cancer, and I think I'm very happy to see from an advocacy group somebody be present, being proactive, because this is in bladder cancer, and thank you very much. We have very few in bladder cancer that are doing this, and the awareness is very important. But certainly the two issues a biomarker can address is the diagnostics. The diagnostics at our moment neither effective or cost effective. The therapies are definitely not effective and cost effective, and I think one of the major issues we have in bladder cancer is the follow-up. The follow-up, unfortunately, is not effective or cost effective, specifically in non-muscle invasive bladder cancer. And limited new developments, but that's going to change. So the goal in non-muscle invasive bladder cancer is certainly, and this is what we start with, eradicate the cancer. Prevent or delay the tumor recurrence, prevent or delay the tumor progression, these are the important things, prevent the panureteral disease, and preserve the survival. But we never ever talk about the fact of the multiple cystoscopies, as Jim Cato said, and what we are doing actually to do that, to achieve that, and the over-diagnosis and over-follow-up we're doing. Unfortunately, our diagnostics, as I said before, are not adequate for this disease because our gold standards, the cystoscopy and cytology, are good, but not good enough. They're invasive, they're expensive, and they're time-consuming for the patient to come on a regular basis to see you, and for you, the procedure is in the office. For the urologist, in many scenarios, it's a good thing because it drives them money, but it's certainly not the right thing for the patient. And the problem is, despite all this, our diagnostics are not perfect. We have still a false negative rate that is pretty significant, up to 20%, and that's what we see from the blue light studies. So, the promised land of biomarkers. Biomarkers will change everything you do. And for 30 years, we've been all working on biomarkers, and we have not found a single biomarker that can make that difference. Because there are some benefits you expect from biomarker. Certainly in certain scenarios, in a non-muscle invasive, you hope that it will reduce your frequency of cystoscopies. You also want to identify those patients that will get progression, but before they have a full-blown progression, so you can intervene early on, or get them even in their progression at the earliest stage, so it's not metastatic and you lost the patient. By achieving these benefits, you not only will improve quality and length of life, but you also will reduce cost. Now, the downside is this biomarker needs to be a good performing biomarker, because if it doesn't perform well, you're losing safety. You miss recurrences, and on the other side, if a biomarker has a low specificity, positive predictive value, you might even increase your number of interventions, unnecessary interventions, right? And driving anxiety and cost for the patient. Unfortunately, up to 2018, and we've done a bunch of reviews, and we are in the guidelines, Juan Palu and I, and we think of it, and Hugh is as well. And unfortunately, there's no biomarker that has entered any of the guidelines. Because, yes, most of the biomarkers that so far have been used, the sensitivity is superior to cytology, specifically for low grade, because cytology doesn't perform in low grade. And I think the question is, in low grade, at all, do you need a cytology in a follow-up of the patient? Because the progression rate of a low grade is very low. But at a population-based level, this is another question. Specificities of most of the biomarkers has been lower than cytology, and there's no single biomarker that is superior to cystoscopy with cytology. So there is no good ideal biomarker to date. It is because we have asked the things to a biomarker in the wrong question. The performance of the biomarker you expect is according to the clinical scenario. For example, if I have, it's not a one-size-fits-all. In a screening or early detection scenario, that means a patient comes with macrohematuria to you, or a screening population, let's say we identify a high-risk population, heavy smoker, long-term, and you put it in a screening. There's no screening that is yet recommended. What you expect is a high negative predictive value. You don't want to miss a cancer, so you want 100% probably negative predictive value. But in the surveillance, that was what I was saying before to Jim, you expecting a negative predictive value, but you starting to squeeze that you want a positive predictive value because you don't want to do unnecessary testing and lower the recurrence rate. And even if you miss a cancer, who cares in a low grade? Because in 3 months from now, if you're going to do a cystoscopy interval, you're probably going to get it. And that cancer will not change the biology and will not be life-threatening, right? But in a high-grade cancer, there you want the negative predictive value as well, because in 3 months from now, if you miss it, you're going to have a serious problem. This will advance a stage, your metastatic rate will increase, and you cannot save that patient. So the 4 questions I want to address is, what is the true diagnostic performance of EpiCheck? Does it improve our predictive accuracy beyond, not only in an abstract as a single biomarker, but adjusted for all the clinical factors we know today? And in clinical scenario, we're using factors. What was his previous cancer? What was his frequency of recurrence, and so on? And is its performance affected by those features? And how will it change our clinical decision-making? So we received the data graciously from the company, from the trials that Fred Witches did, and a very external view, without having any insight of what analysis they had done before. We looked at the data and we set our references for a positive test or for a positive endpoint a little bit different than Fred did. We said positive pathology is cancer, but also positive cytology is cancer, just it was missed on the cystoscopy, because cytology is by definition, a positive cytology is cancer. So we took it both, and that makes a discrepancy of approximately 6 patients compared to the data that Fred showed you. What did we find? For detection of any cancer, we find a 94% negative predictive value, which is very good. The positive predictive value was a little bit around half of the patients, so a little bit of unnecessary testing. But we also asked the question, that is the clinical question, are we going to miss high-grade cancer, which is the most important cancer to look for, because that you definitely don't want to miss. The accuracy of the test was 85%. If you look at high-grade cancer, the negative predictive value goes almost close to 100, 99%. Now, you got to have a positive predictive value and do a few unnecessary testings that are going to be, but you're going to accept it in this scenario to not miss the high-grade cancer. The accuracy increased for high-grade cancers, those that you're looking for, up to 80%. So does it improve our predictive accuracy? Now I show you these numbers. You're going to say, well, it's good test. But what if it's just measuring something we already know from the previous stage of the cancer, from its recurrence, something that a nomogram or a mathematical model could predict us already without adding this test? So in univariable analysis, we looked at the data in 2 ways. we looked at it as an EpiScore test at a cut point, or we looked at it at a continuous variable. So using the cut point, a 15 times in univariable predictive accuracy for predictive odds ratio for detecting cancer. Now, adjusted for all the variables that we know and have from the past from the patient, those tests not only keep the performance accuracy or the odds ratio, but it's quite significant compared to anything else. Not only they're the only significant variables to predict in addition to the previous frequency of the cancer recurrence or the time from the last recurrence, but it is pretty significant and pretty impressive in a multivariable analysis. If you look at it in a nomogram, the nomogram is just there for you to give a feeling of the additive value or the breadth of the test performance. And you see if you put the EpiScore, it's the most impressive predictor of a cancer presence than any other one. Age, gender, the EAU risk stratification, or the time from last TURBT, or even if you had intravesical therapy. So pretty powerful. The base model, so if we today use everything we know about the patient, I could predict you with 60% accuracy if this patient is going to have a cancer recurrence at this cystoscopy I'm going to do. If I add that biomarker, I'm increasing it to 82 to 84, depending if you use the continuous score or as using a cut point. So over 22% improvement in predictive accuracy. There's no single biomarker, and I've done maybe 15 years tests on biomarkers for screening or for whatever scenario in prostate cancer, bladder cancer. I've seen such a big jump in your decision making. So basically what I'm telling you is if I give you all the information that a clinician has today, he's barely above, if he integrates that, barely above of a flip of a coin knowledge or information to make a decision if this patient has cancer now. That's why he does all the frequent testing. But with this biomarker, you're jumping a big difference. Now for high-grade cancer, which is the cancers you want to detect. In univariate, this test performs dramatically. It's a powerful odds ratio if you look at 58%, but a very wide confidence interval. If you adjust it for all the known clinical factors that we know, it stays significant and still a pretty significant odds ratio. We agree that the confidence interval is quite wide, but for the continuous score, pretty narrow and pretty performing very well. Here again, if you look at it at a nomogram, it is the most significant. A jump in the score will give you a lot of increased probability of having a cancer compared to anything else. What is the area of the curve of everything we know currently? 70% for high-risk cancer. And if we add it, over 24% improvement, a big jump. So I think in the current statistics, we can say this biomarker adds significant value to what we already know. So is it affected, its performance affected by patient scenarios? What I want to say here is if the patient is a smoker or non-smoker, will it perform differently? Its additive value to everything you know will be differently. Or if a patient is male or female or any other factor, risk factor, age, anything performs it? No. No matter what group, subgroup you're in, it still improves your predictive accuracy for all cancers up to 80% and close to mid-90s if you are looking for high-grade cancer. So it's a very stable, robust test, not affected by any other factors. So my last question was, does it improve the clinical decision-making that you will have tomorrow? If tomorrow you go to your office, how many cystoscopies will you save if you use this test? And how many cancers will you miss if you use this test? What is the risk associated with it? So if you look at it, we already said before that, Fred, I think you presented that, the AUC of this test. We have used a little bit different definitions, but the AUC is pretty good. That's the area under the curve. If you use area under the curve, it's good, but what does it tell you for your clinical decision? The problem with the AUC is it does not adjust for the prevalence of the disease in your population. It might be in certain populations that are referred to Fred or my clinic, these are a little bit higher, more frequent cancer recurrences, or different non-muscle invasives, as one sees in a community, or different regions, or different countries, smoking affecting it, and so on. And the ASC does not adjust for the sensitivity and specificity you care about. Because I told you just before, depending if the patient had low-grade cancer or high-grade cancer in the past, you will expect something else from the negative or the positive predictive value of that clinical test to implement it. So there's a way to adjust for that, and it's called clinical decision curve analysis, and that's where you wait for the prevalence, and also you wait whether you like more sensitivity specificity, that's a statistical model, and you also can vary your threshold probability. What I mean with that? For me, if a patient comes, I will ask him, how worried are you about your cancer coming back? And you have your anxious patient, he's going to say, if I have 5% chance of having cancer, I want a cystoscopy. And I can tell him 5%, don't worry about it. But he wants a cystoscopy. But there's going to be another patient who's going to tell me, I want the cystoscopy, only it's a 15% chance of cancer. Because I'm more relaxed. So it's going to be how risk averse are you, even though you explain to the patient the probability, so you can put your threshold where you want. So this is what we do, including that in the decision curve analysis, how many cystoscopies can we avoid while not missing a single cancer using nucleics, EpiCheck. So this decision curve is quite complex to explain, but this is if we would cystoscope all the patients, and we're looking at the net benefit. If you use your current prediction with all the variables you know today, that I told you before, doesn't change much. You still have to do a lot of cystoscopies. But if you use the EPI score, you will see that actually your number of outperforms the other tests dramatically and saves you a lot of cystoscopies, and here's the threshold probability. So in numbers, I know those curves are very complex to understand. In numbers, to make it a little bit more understandable, palpable for you, if I have a threshold probability of 10%, so if I say, look, I have a cancer, if I miss a cancer, I'm ready to take 10% risk of a cancer, I want a cystoscopy. If the patient tells us that, I'm saving 36% of the cystoscopies while not missing a single cancer. And that goes further up. You see, obviously, if you put your threshold higher, you will have more cystoscopies avoided. And if you look for it for high-grade cancer, same thing. What you already know is equally to doing a cystoscopy in everybody. If you use the EPI score, you're dramatically increasing your clinical value, saving a lot of cystoscopies. And if I do not want to miss a high-grade cancer, and that is the clinical question that is, I think, at hand, and the most important question, with 10% of threshold probability, I'm saving 77% of cystoscopies. If I use this test, and I could forego cytologist cystoscopy in 77% of our patients. And if I go higher, even goes to 80 or 90%. So I think this is how this test can help you avoid cystoscopies in a discussion with your patient in a highly accurate way. So in conclusion, I think looking at the data externally, totally unbiased, and actually with a critical view, I was not expecting to see such a good performance. I think it has excellent diagnostic performance with a negative predictive value of 94% for any cancer, 99% for high-grade cancer. It improves the accuracy beyond what we have already clinically today by 22% with any cancer and 26% for high-grade cancer. This is the biggest jump I've seen any biomarker added to clinical scenarios. And it's a diagnostic test that is quite robust. I'm not saying robust how the assay is performed, but robust based on a clinical patient that comes in with his personal features. Being a smoker, female, and so on, it will not affect your test performance. We had that problem with NMP22 and other biomarkers. And then finally, it can significantly improve your clinical decision-making, reducing the unnecessary cystoscopies and cytologies, and therefore, which we have not shown yet, lowering the cost, but it's a self-explanatory, improving patient care and quality of life. Thank you very much.
Rock, excellent presentation, and you see you are now out of time, so you're exactly within your 20 minutes. No, that's great. So if there are no questions, we will proceed with the next presentation of Roberto. Yes, sure, of course.
Just one quick question.
Yes, sure.
What about the use of a non-invasive test like this at a primary care level? Would that aid in getting earlier diagnosis? Because most general practice clinicians make a decision of who to refer based on no test at all, just on their basis of thinking, is it male, what is their age? And that's their decision process to decide whether to send somebody for further tests. Is this something that we could use to great benefit for the patient community at a GP level?
I think your question is one of the most important questions. Where we can make a difference in bladder cancer survival is not by using a robot or better chemotherapy, it's by detecting cancers early on. And a lot of problems we have, specifically in females, is the late diagnosis of cancer, macrohematuria misunderstood, not referred, and maybe reference done for the wrong reason, plugging up, and the wait time to get a cystoscopy. So this test could be fantastic. The answer to that is we don't know it because the trial Fred did is actually in a surveillance setting. But looking, my gut feeling, I tell you, with no data, and Fred might be better to answer that, is its high negative predictive value in a non-muscle invasive gives me the feeling that you could save a lot of embedded triage the patients, and by a test in that setting could be easily used in any setting, any gynecology, primary care, to select the patient to send, and maybe thereby sending the right patients, and more often the right patients. I don't know.
Yeah, same gut feeling, but again, you would have to look for that. It's a different population with different statistics, so test performance will be different, but would be a good idea to test that. Okay, thanks. Roberto.